Hello, my name is Monica Satake, and I'm with True North Training and Compliance. It's my honor to be with you today and share some valuable information regarding OSHA and patient safety. I want to say thank you to you for your dedication to the dental profession, specifically during this year. 2020 has certainly proven its share of challenges, and I've had the wonderful opportunity to work with many of you in navigating new and best practices during the pandemic by providing you with in-office training, our written program, mentoring, frequent email updates, along with a lot of emails and phone calls answering your questions. It's been my pleasure to watch you rise to the challenge and continue to meet the needs of your patients by maintaining your excellent standard of care. Thank you. I've been in the dental field for nearly 30 years, first as a certified dental assistant and an expanded functions dental assistant, then as an instructor at their prestigious dental assisting program and an associate professor at the College of Western Idaho. I graduated summa cum laude with a Bachelor of Science in Education from the University of Idaho and a Master of Health Education from Idaho State University. In 1991, I started traveling all over Idaho, teaching expanded functions, and met many of you on those travels. We have an amazing dental community, and I am really blessed to be part of it. For the last 2 years, I have served on the item writing committee for the Dental Assisting National Board, where I've had the honor of working with some of the brightest minds in the world of infection control and patient safety in Chicago. And this year, I completed their newest certificate program for dental infection prevention. At the end of this presentation, I will highlight some of the services that are offered through True North Training and Compliance, which I started as a result of seeing a need in our community for training and mentoring. The goal of this presentation is to give an overview of the requirements for an OSHA and patient safety program, with more in-depth focus on water and sharp safety. This presentation does not meet the criteria for the federally mandated annual OSHA update, as it is not as in-depth and doesn't provide an opportunity for questions and answers at the end of the session, which meets OSHA's employee right to understand standard. I will cover briefly some of the whys and the whats of OSHA training. To begin with, OSHA training requirements start upon hire at the initial assignment of duties. Needs to be part of the intake process, and employees need to be trained before they are required to provide and perform duties that would put them in a situation where they could be at risk. After that, each office is required to do an annual OSHA update that is pretty in-depth, and outside of that, when changes are made, such as when the manual is updated, when new processes are introduced, and if there are changes in standard operating procedures, such as PPE and respiratory PPE that we've been introduced to this year that is new. For some of us, it's new. And so we need to, again, make sure that we keep all of the training records, documentation, written documentation in our program for a minimum of 3 years. We allow for questions and answers to make sure that employees understand. And then we make sure that we have a bloodborne pathogens elements of training that details what we talked about in the training, and a list of people who attended the training, the name and credentials of the person that provided the training, along with the signature on the form. And that all needs to be maintained in the documentation for a minimum of 3 years. Some of the most common violations found in the dental field, you can see there are 10 in this image here, and I would also add one at the end of this. Most commonly, inadequate emergency eye washing stations, other things like waterline management documentation, inadequate PPE, especially right now specific to COVID. We want to make sure that we have proper secondary labeling. Sometimes our employees have no knowledge of global harmonization, and we want to make sure that they understand global harmonization. We want to make sure they understand the types of chemicals they're working around and the precautions that are needed to work with those chemicals, and have a chemical index that discusses the types of the chemicals that are in the office. We want to make sure that specific to COVID, if we added another common OSHA violation just this year would be a number 11 up in here somewhere, would be the lack of respiratory protection program. And so making sure that we have adequate PPE specific to COVID. Is it business as usual, or have we made changes in our PPE? We want to make it sure that we take a look at our supply chain. Do we have enough respirators if that's what we're using? And do we have our employees fit tested if they're using a respirator? And I'll talk a little bit further about that in just a minute. But making sure that we have adequate training and documentation of those things. So what does the written plan look like? Well, some of the categories that would be involved in a written plan are general safety standards and OSHA overview, employer and employee responsibilities, hazardous communication plan, SDSs, global harmonization. Do we have an emergency action plan? What are Idaho's nitrous oxide requirements? Is our staff trained to understand the risks of working around that, and do they know how to administer and monitor that with direct supervision? Bloodborne pathogen exposure control plan, including a post-exposure protocol, respiratory protection program for those of you using respirators, infection control plan or standard operating procedures, including interim guidelines, workplace ergonomics. What are the standards for OSHA? What are the requirements for Idaho radiation and monitoring? What do our training records look like? Do we have training records? Are they up to date? And where are our waste manifests and the record keeping for that? The written program must be customized to the workplace. It needs to be accessible to all employees at all times. Some of us like to have the physical manual on a shelf that we can get to right away, which is fine, but we need to make sure that it's easily identified, that it can be accessed at any time, and that it is current. If you're someone that likes to have a more digital written program, that's also fine. It seems to be a little easier to update when needed. It needs to be on a shared drive so that everybody can access it though. And if it's on a computer that's password protected, it needs to be accessible by all of the employees so that they can access it at any time. So a couple of things that you want to take a look at with your written program is it current? And do we have all the components of it? To go a little deeper, and again, this isn't all inclusive, but some questions that you would want to ask to see if you feel like you might need to update your stuff. Exposure control program, does it have the bloodborne pathogens epidemiology? Have we taught our staff what hepatitis is about? What is HIV? Any of the bloodborne pathogens? Are they aware of immunizations? Do we have the appropriate documentation for their immunizations on file? And in the event that we have a significant exposure, what are the appropriate measures for that? Regarding hazardous communication, do we have a global harmonization updated? The SDSs, do we have a chemical inventory index? If we have items that we're not using any longer, we don't just throw the SDSs away, we put them in an archived folder and make sure that those are kept on file. Should there be any exposure, and later on, and we'll talk about why later on, but we need to make sure that we don't just throw SDSs away, that we keep them in an archive folder. Secondary labeling, making sure that if anything's taken out of the original container, that it is labeled appropriately so people know what's in it and how to handle a situation if they're exposed. Again, respiratory protection for those of you using respirators, workplace ergonomics, an emergency action plan, eye and face protection, nitrous oxide, oxygen training, radiation regulations and protocol training, standard operating procedures, and those specific to best practices during COVID, training program for each of those things, and what documentation and forms do we have for each of those things. So let's take a look briefly at COVID-19. So where do we get all of our information from? There are a lot of different agencies, and since March, we've had guidance from so many different resources that it's really hard to keep up, and it's very confusing. We have guidance from the CDC, OSHA, ADA, and ADHA. So to go back to basics, one thing that OSHA states when it's designating risk in a particular area, it would be taking a look at what tasks you're performing when you're on the job. And you can see here that if we're performing aerosol generating procedures, then we are considered to be in a very high risk category. So employers need to assess hazards to which their employees may be exposed, evaluate the risk of each exposure, and select, implement, ensure worker use controls to prevent exposure. This table describes dentistry work tasks associated with the exposure risk levels in OSHA's occupational exposure risk pyramid, which may serve as a guide to employers in this sector. So again, we can see that we fall into that very high risk category. Well, who needs to know this information? Well, according to OSAP and OSHA and Dental Quest providers, we need to take a look at the dental healthcare personnel, paid and unpaid, dentists, dental hygienists, dental assistants, dental lab techs, whether they're in office or commercial, students and trainees. So if you have externs that are in your office, they need to know this information as well. Contractual personnel, other persons not directly involved in patient care but potentially exposed to infectious agents, such as administrative and clerical. And something that I've gotten several questions about would be those that are actually cleaning the dental office at night. So they need to know the information as well to make sure that they are kept safe. So because of all of these different agencies and the different guidance, a group of very bright individuals got together, my colleagues from across the United States, and put together a resource. And their collaboration resulted in this resource called The Best Practices for Infection Control in Dental Clinics During the COVID-19 Pandemic. It has easy to use information and checklists, which I'll give a brief overview of those here in just a moment. Keep the link handy though. Don't just download the PDF, because whenever there's a change in guidance, they work very hard to make sure that it's updated in this document. So don't just download the PDF and be done with it. Make sure that you access it often via the link so that you are operating for the most current information. So one of the things to be aware of in making sure that your office is protected is taking a look at the hierarchy of controls with dental examples. So you can see that it starts at the very top here and begins with elimination. We want to make sure that we are screening our patients prior to the appointment and upon arrival. And if there are any symptoms, we want to make sure we isolate those patients. And then we move down to substitution. If we have someone that needs to be seen and they're at risk or that they've been exposed, we want to see if we can maybe replace by maybe doing teledentistry or such. And then we want to make sure that we use engineering controls to isolate people from the hazard. Do we have enough space in the infection control zones to isolate and separate with physical barriers? Do we have high-speed evacuation in conjunction with isolation? Are we going to use hand instrumentation versus Cavitron? So you can see here that the very bottom is where we have our PPE. So we don't just start with this, we start here at the very top of the hierarchy of controls and go through all of these steps before we get to the PPE part of it. Even here with the administrative controls, we are changing the way that we work. Managing visitors, limited points of entry, adjustment in appointment scheduling, making sure that our people are trained in all of these areas. And so these best practices, this resource is designed to help reduce the level of risk from very high through a hierarchy of safety protocols that have the greatest impact on clinical safety. So some of the checklists that are in this resource include preparing the dental clinic prior to the patient appointments. And again, we're talking about changing behaviors with our patients who are coming into the office as well. And it starts even before they get to our offices. Do we have a screening protocol that we maintain with patients via phone call before they even get to the dental office? How do we communicate to the patients if they have COVID-19 or are living with someone that has been diagnosed with COVID-19, is symptomatic? Are we allowing visitors in our office? So making sure that we prepare prior to the patient entering our practice, and making sure that we communicate that. We have a lot of elderly patients that this is something that they're not used to, and some of them haven't been out at all during COVID, and so this might be the first time that they've been out. And so making sure that we really communicate with our patients prior to them coming to the dental office. And then delivering patient care. Making sure that we have places that if a patient does come in and we're screening them and they do have an elevated temperature, well, how do we isolate and what do we do? Also making sure that we ask good questions prior to them coming in and when they come in, and making sure that we document those things. We also need to make sure that we're screening our employees. We're not exempt from this. And so making sure that we ask these questions of our employees and then we document these things. And also probably making sure that we are changing our behaviors as far as sick leave goes. We want to make sure that we keep good documentation of this and maintain it after the form is filled completely out. Visitor screening, if you have someone that does need to have assistance, we want to make sure that we screen those folks as well, and be compliant with all of this as far as taking temperatures and writing the information down. Past the screening for the visitors and the patients, then our changes go into actually treating our patients. What does our PPE look like? Our donning and doffing. It looks a little different because we need to make sure that we are using universal source control, having patients and front office staff wear masks in the office, and making sure that if we are changing our PPE, that we have a designated area outside of the operatory for donning and doffing PPE. Standard precautions will be the foundation, but there will be modifications for the airborne illness. For now, N95s and a shield fall under the fit under fire, and if there's a known hazard, we need to use the N95s. Our standard operating procedures will have changed. There needs to be an initial and annual fit test and a respiratory protection program. We need to make sure that we're wearing the appropriate PPE for the task, depending upon the dental procedure. And the type and the amount of PPE will vary depending upon the level of risk in the community and the type of treatment. So for instance, protective gloves, safety glasses or shield, a mask, gown or lab jacket, and then we need to make sure that we properly dispose of the contaminated PPE and waste appropriately. And we have appropriate N95 and KN95 training. One thing that we want to make sure that we're aware of is, what type of precautions we'll use depending upon the treatment. And so for splashes, we're going to wear the gloves, eye protection, gown, and surgical mask. For aerosol generating procedures, we're going to wear gloves, eye protection, gown, clothing, and an N95 or higher. We need to make sure that our N95s are fluid resistant. And for suspected or confirmed COVID-19, we're going to wear gloves, eye protection, gown, clothing, and an N95 or higher. Again, making sure that we have fluid resistant masks. We want to make sure that we have the appropriate amount of PPE and supplies to support our patient volume. So that's where when we get into our scheduling differently, making sure that we have the appropriate supplies for the number of people that we're seeing. We have to be aware of PPE utilization rate. So this is where your inventory program might need to be beefed up a little bit. If PPE and supplies are limited, then we have to prioritize dental care for the highest need with our more vulnerable patients first. Disposable items should be treated as such and disposed of after each patient. Decontamination should be a last resort. So that's when we have to adjust the schedule accordingly. So really, we're not back to business as usual. If you're having to reuse your respirators and PPE, you'll need to adjust your patient schedule and not doing the optional procedures, and go back to the hierarchy. PPE is at the bottom of the hierarchy and elimination is at the top. Some of you might be asking about best practices for decontamination of respirators. And the answer is there's no best practice for N95 reuse and reprocessing. These are designed to be disposable items. These methods are the methods are options for times of crisis and should not be implemented as routine if mask supply is sufficient. Based on the resources available at each institution, the optimal strategy for each person or institution will vary. So again, making sure that you have appropriate supply for the number of patients and the types of procedures. If you are using respirators, if there's a known hazard, there needs to be a respiratory protection standard. Not much attention in the dental office has been put to this prior to now, but the fit testing and the respiratory protection program needs to be covered before required or voluntary use. Even if it's interim, we don't know what the final guidelines are going to be just yet. There has been some confusion regarding the OSHA memorandum sent out on March 14th, so I'm going to clear that up. OSHA has allowed the field offices to exercise their discretion in enforcing the annual fit test, but not the initial fit test. And I've had lots of questions about this. So the entire memo and their April update clarify the fact that they are talking about relaxing the annual fit testing, and this is because of the limited supply of PPE, of respirators, but not the initial fit testing. Because we have to know how to use it, and we have to make sure that we can actually wear a respirator. There are those with certain medical conditions that cannot wear a medical respirator. So you can see with this graphic, we want to make sure that we have a written respiratory protection program. We have a medical evaluation that has to be sent in to an approved person, and it can't just be the dentist. It needs to be a licensed practitioner, a medical practitioner that would evaluate the medical evaluation. They may call and ask further questions if they have concerns about anything that would be on your medical evaluation. And then when that medical evaluation is approved, you would take that and go to someone that does fit testing. And that would be your ticket to be able to get your fit testing. If the medical evaluation, if you fail the medical evaluation, then you wouldn't move on to having your fit testing, because you would have some sort of medical issue that would prevent you from wearing the respirator, which is why it's important to have the initial fit testing to make sure that you don't have an underlying health condition that would prevent you from wearing your respirator. So there would need to be training along with your fit test. You would need to make sure that you perform a self-seal check every single time you wear your respirator. And then we want to make sure that your fit testing is done by a program administrator who is qualified and authorized to do the fit testing. So we've been given permission during this fit under fire time to use KN95 respirators for this emergency period only. Any other time, we would be required to use NIOSH certified respirators, which are N95s. That's the equivalent in the United States. You need to be trained on why you need to use a respirator, what the respirator can and cannot do to protect you, how to properly inspect it, put it on, take it off, and use it, how to do the seal check every time, how to recognize medical signs and symptoms that may limit or prevent you from using it, maintenance and storage of a respirator. And we're only talking about like half-face respirators like the N95s and the KN95s, not the PAPRs that have the air tanks and stuff like that. That's what this is talking about right here. And so making sure that you understand the respiratory protection standards, and then reuse and decontamination. And again, the decontamination is, it's not ideal. These items are designed to be disposable, and so reuse and decontamination is kind of a last resort. So making sure that you're understanding the process of all of that. Verena Solutions stepped up to the plate when we were low on KN95s and N95 stock, and they reached out to a supplier in China, and they have a stock of KN95s. They actually did send them through the testing process, and they have been NIOSH tested to a 99% efficiency. They do have N95s as well, and you can go to their website at Verena Solutions /masks.com and order and get a 20% off with this code. And also get a complimentary 5-pack of ear savers. If any of you have used KN95s, you know that they don't have the elastic band that goes around the head, which is why the KN95s are not ideal. Typically speaking, they're not, they don't fit secure enough against your face to create the seal necessary to use during the aerosol generating procedures. Just the N95s work for that. However, the KN95s, Verena Solutions has the ear savers that help. If any of you have worn the KN95s for a long time, you'll notice that they start hurting your ears if you have them on tight enough. And so not only do the little plastic adapters help save your ears and lessen your headaches, but they also get them tighter on your face to help with that self-seal. And so if you're using N95s or KN95s, you do need to have a fit test. I have heard some colleagues say that KN95s are a little harder to pass a fit test, but they, if they have the adapters where they can tighten them up, then they can get them to pass. And so if you need a supply, you can contact Verena Solutions, and they can send out those items. So I put together some frequently asked questions that I've been asked throughout this, and thought I would include them here. So the question is, what if a healthcare worker thinks they have COVID or has been exposed to someone with COVID or suspected of having COVID? Well, the answer is, because we've done our screening every day, we continue to monitor and manage the healthcare providers by taking the temp and monitor for signs and symptoms at the beginning and ending of the day, and we document it. We document the absence of symptoms as well. We need to have less than 100 degrees. If it's above 100 degrees, then we go home and consider that we might be sick. Look at the policies and procedures for sick leave. We don't want to feel like we have to come to work if we're sick. Question, what if a healthcare worker tests positive? Well, the answer is we contact our health department for direction on how to proceed. We identify the close contacts, other workers, and patients that they were in contact with. It's critical to have documentation of the employee screening for this very reason. Masks and eye protection should be worn when near workers and patients who do not have a mask on. And here is the number for the Central District Health that we would call to get further information on how to proceed. Question, when can we come back to work if we have had COVID? Well, there are two strategies that are followed. One is symptom-based and one is test-based. Symptom-based strategy would be that with a healthcare provider who has mild to moderate illness and not severely immunocompromised, At least 10 days, more on the end of 14 days, have passed since symptoms first appear, and at least 24 hours have passed since the last fever without the use of fever-reducing medications, which is important to note that, and no symptoms. Patients who are healthcare providers who are not severely immunocompromised and asymptomatic throughout their infection may return to work when at least 10 days have passed since the date of their first positive viral diagnostic test. So that's the symptom-based strategy. Test-based strategy then, those symptom-based strategy with severe to critical illness or who are severely immunocompromised would be at least 10 days and up to 20 days have passed since symptoms first appeared. At least 24 hours have passed since last fever without the use of fever-reducing medications, and symptoms have improved. Those healthcare providers who are not severely immunocompromised and were asymptomatic throughout their infection may return to work when at least 10 days have passed since the date of their first positive viral diagnostic test. Now is the test-based strategy. Now, it's important to note that the reason there are two strategies is that not everyone has access to the test-based strategy, and we know early on that tests weren't readily available, so that's why there are two different strategies. And if we live in a more rural community, we may not have those test-based strategies readily available to us. So test-based strategy then would be those healthcare providers who are symptomatic, resolution of fever without the use of fever-reducing medications, and improvement in symptoms, for example, cough and shortness of breath, and their results for their tests are negative from at least 2 consecutive respiratory specimens collected at least 24 hours apart. And so the test is using an FDA-authorized molecular viral assay to detect SARS-CoV-2. So 2 tests stating that they're no longer symptomatic and that they are negative. What if a patient calls for an appointment and says that someone living with them has COVID? The answer is that it's probably wise to postpone the visit to see if they become symptomatic or COVID positive. And again, we're looking at the possibility of a telehealth visit in this instance. So worker exposure, again, if we take a look at if we're using our universal precautions and we're using the appropriate PPE, because in Boise, the Meridian Boise area, we have a lot of cases around here. So the chances of us coming into contact with someone that has COVID or and is asymptomatic is pretty high in this area. Some of you in the more rural areas may not have that, but let's take a look at what that looks like with exposure. So the healthcare provider who had prolonged close contact with a patient, visitor, or a healthcare provider with confirmed COVID-19. Here's why we have appropriate PPE and training for it. So what if you have a patient that comes in and you find out later when we do the check on our patients following their dental visit, when we call for their 14-day follow-up, what if we find out if they are COVID positive? Well, if we have the appropriate personal PPE equipment versus if we don't. And so PPE, if the healthcare provider is not wearing a respirator or a face mask, then we have to exclude them for work for 14 days after their exposure. If the healthcare provider is not wearing eye protection, if the person with COVID was not wearing a cloth face covering or face mask, advise the healthcare provider to monitor themselves for fever or symptoms consistent with COVID. Any healthcare provider who develops fever or symptoms consistent with COVID should immediately contact their established point of contact to arrange for medical evaluation and testing. Now, if they are if the healthcare provider is not wearing all the recommended PPE, for example, the gown, gloves, eye protection while performing an aerosol generating procedure, the same thing. We'd want to monitor and make sure that there are no symptoms. If they are wearing the appropriate PPE, then we assume we're protected and we move forward. Again, here is the important part of this slide. We want to make sure that we're calling our patients 48 hours after their appointment to follow up and make sure that they, how they're doing, to see if they are symptomatic. And then that kind of sets the tone for what we do next. What if a front office staff or sterilization tech who is not providing direct patient care comes in contact with a COVID positive patient? Well, the answer is unless they've been in the room with the aerosols, they would not be excluded for work for 14 days. We simply monitor and document if we become symptomatic, and then we go home. When we're not providing patient care, this is when we use universal source control. The staff should always be wearing an appropriate level 3 surgical mask around the office, includes the front office staff who are still using sneeze guards. So moving forward out of the COVID-19, and I'm guessing that some of you will have questions about things that I didn't cover because again, it's the pretty basic information in there. I think some of us have been overwhelmed with the amount of information. So if you have further questions, please don't hesitate to get in contact with me and ask those questions, and I can give further guidance on that. So although we're in the midst of the COVID-19 pandemic that's driven so many new protocols for patient and team safety, we cannot forget about safety measures that are foundational to dental healthcare workers. At the forefront in the delivery of dental care is sharp safety. Especially sharp safety is related to dental needles. Injuries sustained from needles contaminated with blood containing HBV and HCV positive sources are at risk of transmission after percutaneous exposure. Even for HIV, although the risk of transmission is extremely low, it's not zero. So OSHA estimates that approximately 5.6 million workers in the healthcare industry and related occupations are at risk of occupational exposure to bloodborne pathogens each year. Studies have estimated that between 600,000 and 800,000 needle stick and other percutaneous injuries occur annually to healthcare workers. And there is a considerable underreporting of these injuries, which we'll also talk about. So the first thing we're going to talk about here is in engineering and work practice controls. These must be the primary means used to eliminate or minimize exposure to bloodborne pathogens. Where engineering controls will reduce employee exposure by removing, eliminating, or isolating, they must be used and documented in the exposure control plan. So we have two different things here. We have engineering, and then we have work practice controls. And I'm going to give some detail about the difference between those two. So in both of these instances, we're trying to control exposures to percutaneous injuries. So work practice controls are those measures that reduce the likelihood of exposure by altering the manner in which a task is performed. So for example, prohibiting recapping of needles with a two-handed technique. This work practice control is behavior-based, and it is it's changed by changing the way one works to have a safer outcome, and altering the manner in which a task is performed will reduce the risk of exposure to blood or other potential infectious materials that the employee comes into contact with. Engineering controls, however, are the devices that are used. That they're measures such as sharps disposal containers, self-sheathing needles, safer medical devices. These reduce sharps injuries. They isolate or remove the bloodborne pathogens hazard from the workplace. It requires that the oral healthcare provider do the task in a safer way to minimize any exposure to blood or other potentially infectious materials. I want to introduce a fairly new product that was just launched this year that would fall into the category of engineering controls. If you want further information about this, you can go into the Needle Stick and Prevention Act on the OSHA website and find the forms for this. But what I'd like to introduce you to is a product that I was introduced to in January at the OSAP National Conference in Chicago, and it's called a Simple Cap. It's a device that's, it's a self-sheathing needle, and so it's easily threaded on any dental aspirating syringe. It's designed to protect the dental professional during all phases of the injection. There are many opportunities for needle stick during assembly and disassembly, as well as during the injection itself. And so Simple Cap, their engineers have this covered by extending the sheath below the needle end. It can be safely aligned and assembled, and because of the attention they put into the threading system, it makes it easy for smooth assembly and reducing error, providing protection to the user from the start of the procedure to cleanup. The size of the sheath makes its location very clear, and the small hole in the top allows the needle to slide through during use while also preventing a stick in between injections and changing out the carpules if necessary. I'm going to show you a brief video of how these are put together and explain exactly what it is that SimpliCap does. So SimpliCap is specifically designed to add safety to the injection procedure while not inhibiting the procedure itself. The entire procedure was analyzed and broken down step by step to highlight the unsafe steps, and a safety system was added to each step. These features can't be bypassed, so you can be sure that your team is working safely. SimpliCap is the only self-contained and dental needle safety system on the market today. It offers a sense of safety and comfort with little effort from its user. SimpliCap is a device, but it's also a strategy and reduces the risk of needle stick injuries to dental providers. One of the other things with the exposure control plan that it has to contain is documentation of the sharper safety evaluation. Annually, the sharps that you use or the processes that you use have to be evaluated to make sure that you are using the safest protocol possible. These are engineering controls and processes designed to eliminate and minimize exposure. It is an OSHA directive and it is an OSHA standard. So sharp screening and evaluation helps the staff make decisions about clinical and safety considerations before bringing a safety device into the patient care setting. The screening and evaluation consists of the four following components: review of the product literature and information to identify new and possibly safer devices that are available, physically examining the new safety device, comparing the new safety device to the safety device that's currently in use in your practice, and then documenting the information stating that you have evaluated for the exposure control plan. And so Verena Solutions has done a great job of giving you an example of an evaluation form. And if you're interested in this, you can contact me and I will send you one of these SimpliCaps. You also can see at the bottom of this form, there is a special offer for these. And you would fill this information out stating that you have evaluated this product and whether or not you're planning to implement it into your practice. And then you would keep that documentation on hand in your exposure control plan stating that you have evaluated that annually. Verena Solutions has 27 and 30 gauge needles with these that are self-sheathing. And so you can go to www.getsimplicap.com samples, and they will send you a generous supply of samples so that you can try it out and see if this is something that you would like to implement. But again, going back to this, making sure that, you know, even outside of SimpliCap, OSHA requires that you have a form that you can find on the OSHA.gov website to make sure that you are evaluating things appropriately and documenting such. So still on the subject of sharp safety, but moving into the breakdown part of the procedure, we're going to talk about controlling exposures during the transport from operatory to sterilization. Much attention has been placed on this part of the breakdown and sterilization process, but I've had a lot of questions about this. And so it's OSHA standard that states the contaminated materials that are to be decontaminated at a site away from the work area shall be placed in a durable, leak-proof, labeled, or color-coded container that is closed before removing from the work area. The CDC states that minimizing the handling of loose contaminated instruments during transport to the instrument processing area requires the use of work practice controls, for example, carrying instruments in a covered container to minimize potential exposure. So in essence, In order to become compliant with OSHA and CDC, we need to use a leak-proof and puncture-proof container for your contaminated procedural items. Cassettes do offer the protection against instrument pokes, but still expose everyone to the risk of bloodborne pathogens through leaks and spills. And so those cassettes that some of us are using that have slats and holes in them, we would need to make sure that we place them inside another container in order to comply with OSHA and CDC in transporting them from the patient treatment area to the sterilization area. A couple of other things regarding safety for the healthcare worker would be the PPE during breakdown and transportation. Making sure that we are utilizing utility gloves during the breakdown process, not just, they offer an extra layer of protection from needle sticks, but they also protect us from the number of chemicals that we're using throughout the day. And so making sure that we're wearing the appropriate PPE for this task. So when we're handling the sharps during cleaning and decontamination of the treatment area, as well as when we're transporting from the treatment area to the sterilization area, and then on during the instrument processing. Utility gloves can be decontaminated for reuse. We need to make sure that we watch the integrity of the glove and make sure that it's not compromised with holes or cracks. And they need to be designed by a reputable dental supplier. We can't just buy dollar store dish gloves and have those suffice. They need to be protective enough to protect us during the breakdown and processing procedures. Here are some examples of appropriate transport containers. Again, this is an engineering control. It's a device that's used to keep you safe. It minimizes the exposure to blood or other potentially infectious materials. And again, it needs to be leak-proof and puncture-proof for your contaminated items. The cassettes, if you're using hygiene cassettes for your patient items, then you could put them inside of, and I have two different items here that I'm showing you because some of your cassettes are too big to put in on a tray and have a locking lid. So that's one of the things that you have to make sure of, is that when you're transporting that you have a locking lid. So for some of you where this is a new thing, you could see if the trays that you're using just have a lid that you could purchase that locks. But for some of you who are using cassettes, some of the cassettes are too thick to try and put on a patient tray. So these tubs that are here actually have locking lids as well. And I've heard offices that have purchased these for each tray. And then I've also heard that some offices are using just a single container and bringing it back and forth and just making sure that it gets processed in between. If it's something that is being reutilized from patient to patient, then make sure that it's got a biohazard sticker on it. Make sure that it is disinfected in between. And you would process a tray like this just the same way you would process a patient tray any other time. Making sure that there's no bioburden on it, and then spraying it down and leaving it for the appropriate kill time or disinfectant time. And same thing with these, just making sure that they're being processed in between patients if you're going to reuse them from patient to patient. If you have trays that you can order locking lids for, I would suggest that, that you do that. So despite all of these precautionary measures, accidents do still happen. And so we need to make sure that we are prepared ahead of time for that. What do I do if I get a significant exposure? And when I say significant exposure, I'm not talking about pulling sterile instruments out of the sterilizer and getting poked by a sterile instrument. I'm talking about getting poked by an instrument that's been used on a patient, having a splash in your eye, in your mucous membranes, that kind of thing, where you have potential for a bloodborne pathogen. So we need to make sure that part of our post-exposure management includes developing clear procedures and policies. I can't overemphasize the necessary for training on this program, making sure that it's written, having the appropriate forms ahead of time, having it be easily accessible. Where will we go as far as if we need a baseline blood test? Where do we go? This is something that we need to know ahead of time so that we're we're putting protocol into place that has to happen within a short 2-hour period of time, and we know exactly where we need to go. So for instance, some of our primary health offices, they have the capability of doing if you walk in, you can have a baseline blood test done right away. Some of those primary health offices don't have that, and so you would want to make sure that you are aware of who provides what procedures before you have a situation. What paperwork do you need? Do you have the appropriate paperwork to fill out a form for the exposure incident and take to the healthcare provider? And then what does your follow-up consult with the employer, which is very important and oftentimes it's missed. What does that follow-up consult with the employer look like? What do we do with the paperwork? It has to be confidential. If we're maintaining a SHARPS injury report so that we can have conversations about, in staff meeting, have conversations about better processes for SHARPS, we have to make sure that we can talk about the process of the needle stick or sharp significant exposure, but we need to leave names out of it because those things are confidential. So making sure that we have a rapid response to these exposures is very important, and making sure that we have the appropriate documentation. So this is what that would basically look like. If you had a percutaneous exposure incident, we would need to make sure that we remove the instrument that was being utilized, report the injury to the designated on-site manager. So again, going back to basic OSHA information, who is your OSHA person? Who's your infection control person that you would report to so that you're not running around wasting valuable time trying to figure out what you're supposed to be doing? What is our first aid protocol for that particular incident? Where's our initial report paperwork? What do we do as far as source patient testing? Who handles the source patient questions? Where's our healthcare provider that we're going to go to get a baseline blood test? And then we need to make sure that we're having the written report go to the right person or people. And then again, making sure that we have a post-exposure site-specific evaluation, and then making sure that we have the follow-up consultation with the employer, and keeping the medical evaluation and the follow-up confidential. Part of this would be documenting the route of exposure and circumstances of the exposure incident, identifying and documenting the source individual, and they can decline to be tested. That's their prerogative. Collecting in blood tests for HBV, HCV, and HIV. And then also making sure that you have the appropriate documentation if your employee had a Hep B vaccine to begin with, making sure that you have that paperwork as well. And then also the consultation afterward is a vital component of the required post-exposure follow-up. The healthcare professional will counsel the employee concerning his or her infectious status to include evaluation of reported illness, results and interpretation of all the tests, discussion of the potential risk of infection, and then the need for any follow-up prophylaxis. And then here's one thing I get questions about a lot is how long do we have to keep the paperwork? And the answer is the employee paperwork for a significant exposure must be kept for 30+ years after the employee is no longer employed at the office. So 30 years after employment. Here's some examples. And again, this is just an example. All of these are going to look different depending upon who the healthcare provider is for the medical evaluation. So you can see this is the written evaluation of a healthcare provider, written opinion, but it's going to have basic questions on here about the employee. An employee counseling record, you would make sure that you have the evaluation from the healthcare provider and any suggestions for follow-up processes. And that would be maintained with the employee counseling record confidentially. And so making sure that these things are kept confidentially, and again, for 30 years past the last date of employment for this employee. So moving from a significant exposure of that nature, we're going to go into controlling exposures for waterborne exposures. So it's commonly thought that this is only a patient safety issue, and I often have questions about whether it's an OSHA issue. Here's why I include it in my training. So I'm going to talk about it from the patient safety perspective first. So this young lady was 7 years old. In April of 2016, she was seen in a pediatric dental office in Anaheim, California for a routine pulpotomy. Within 15 days, she became symptomatic and was eventually hospitalized for nearly 2 months with strong IV antibiotics. They went through several different regimes of antibiotic therapy and finally used what they used to treat leprosy. Surgeons had to remove 3 of her teeth and parted the affected jawbone, and the whole process was traumatic and deforming. Shortly after this, another 29 pediatric dental patients from the same dental office had to be hospitalized due to the infection transmission during pulpotomies. Their symptoms appeared in variation from 15 days to 85 days post-op. By August of 2016, the number had increased to 58. This all traced back to a contaminated dental unit water lines. Prior to that, she was a healthy 7-year-old. So moving from that to our immunocompromised patients, many of us aren't even aware sometimes that we have such a large population of transplant patients or immunocompromised patients. We don't have transplant clinics here. We have them in Utah and in Washington, but we don't have transplant clinics here. So some of us aren't as aware as of our immunocompromised patients as others. But in transplant patients, the primary host defense mechanism against Legionella is cell-mediated immunity. And when a patient has had a transplant, they are diminishing or reducing the immune system to keep from having the organ or the blood, if it's a bone marrow transplant, having that reject. And so transplant patients then, because of their immunosuppression, carry the highest risk of Legionella because of their depressed cell-mediated immunity by immunosuppressive drugs. Other immunosuppressive situations involve various types of cancer because of monocyte deficiency and dysfunction. And so those that are in cancer treatment are also at high risk because of their immunosuppression. And so in these 2 instances, we have a heart transplant patient and a bone marrow transplant patient who also, Clay here, has had 2 hip replacements. And so we have those who are immunocompromised in our practices as well. This used to be, Legionella used to be considered an opportunistic disease. So Pontiac fever would be the less severe of the 2, and then Legionella would be the more fatal. Used to be considered opportunistic because commonly those who were most at risk were very old, very young, or immunocompromised. However, it's becoming an increasing risk to the general public, especially because the bacteria is becoming more antibiotic resistant. And the following story is an example of that. In June of 2019, 49-year-old Cameo Garrett, who was stayed at a hotel in Sheridan Hotel in Atlanta, she became ill a short time later, and she was found dead in her home July 9th. She had contracted Legionella. 11 others who also stayed at the Sheridan Atlanta became ill with Legionella. It was traced back to the water feature that was that had not been maintained and was at the Sheridan Atlanta Hotel. And so I looked to see if there were any pre-existing conditions, and I couldn't find anything. It's possible, but the point is that because of the antibiotic resistant bacteria, it's becoming more of a general population risk. And so if you're an oral healthcare provider performing aerosol procedures, you're more than likely to have the antibodies for the Legionella than the general population. However, you may be at risk if your water lines contain colonies of bacteria. So let's take a look at the waterline maintenance. So dental unit waterline quality standards fall under the individual state dental board's purview according to state's dental infection control requirements, which may vary widely by state to state. The EPA mandates that drinking water be maintained at no more than 500 colony-forming units of heterotrophic water bacteria per milliliter of water, so CFUs per milliliter. According to CDC, studies have demonstrated that flushing and purging does not reliably improve the quality of water used during dental treatment down to the 500 CFUs per milliliter level. It helps, but it doesn't reliably improve it. And so there are some recommended practices that go along with minimizing infection transmissions from dental unit water lines. So in addition to flushing appropriately, we need to make sure that we are monitoring, shocking and maintaining the dental unit water lines appropriately as well. So the first question that we have usually is, why does bacteria grow so well in dental unit water lines? Well, the answer is because oftentimes we feel like the water is going through the water lines more like this, but because of the water sitting in between patients, maybe at the beginning of the day, the end of the day, it's a little bit more like this than it is this picture here. So the recommendation is to flush at the beginning of the day for 1 to 2 minutes and be between patients for 20 seconds. So again, the common theory is that dental unit water lines are constantly exchanging and flushing. However, the time between patients is more accurately portrayed by the picture on the right. And again, flushing often and maintaining, and then also making sure that we are putting anti-retractive devices on the water lines, which are typically already installed with your dental units. So biofilms mature at different rates and at random times. So primary source is the municipal water supply. Biofilms serve as a microbial reservoir. They mature at different rates and at random times, and they detach in different sizes and spread. They become planktonic and provide the perfect breeding ground. So we know from basic microbiology that the perfect breeding ground for bacteria is a dark, wet, and it has a food source. So when the plankton breaks away, it becomes food for microbial growth, or an incubator, if you will. So you can see in this picture the different phases, or the different maturation rates, and you can see that the seeds actually disperse. I kind of think of this as like a dandelion. When you blow on the dandelion and the seeds disperse, it's kind of like what's happening in this picture right here. This is actually making sure that when you're maintaining your water lines, you don't have your high-speed handpiece on, because this actually oftentimes will come out of the high-speed handpiece line. And we wouldn't want that to ruin our high-speed handpiece. This is actually a Cavitron water line, and you can see that there's definite microbial growth here as well. So the latest research shows that 31% of water lines fail to reach the CDC's 500 CFUs per milliliter guideline. After thousands of tests and consultations, we know that this happens for 2 reasons. Number 1 is that not all products are easily implemented, and number 2, some are not as effective as advertised. Even for the dental professionals ahead of the curve in the dental unit waterline testing and treatment, it can come as a big surprise, but nearly 1/3 of water lines tested fail to meet the CDC guidelines. So whatever product you're using, be sure that you know the manufacturers for use and the instructions for use, and implement them correctly. Make sure that you understand whether they have a shock component to them or if that's separate, and what can and cannot be used with them. For example, bleach or other things that could go through the dental unit water lines. Some of these, the products can be rendered ineffective, and if they're used with products that aren't compatible with them. So if you're using a product that continues to fail, ask the manufacturer for help, or even try a different product. And ease of use, many of you know, if you have a number of people who are involved in dental unit waterline maintenance, ease of use is very important, and making sure that you have a schedule to keep. If you haven't had a standard of care for your water lines yet, it may take some time to get you to a place of maintenance. Be diligent about it though, and once you get your numbers to a safe place as stated, typically speaking, 200 CFUs is where you want to be. The 500 is at the higher end, and that's for municipal water. That's what they're suggesting for that. But this is water that's being aerosolized, and so making sure that you are right around the 200 CFUs per milliliter. And so once you get your numbers to a safe place that's stated by the EPA, you can focus on maintaining. So sometimes I have seen where when someone initially tests, their CFUs are over 10,000, which is very high. And so sometimes before we even get to a point where we can maintain, we have to shock 3 times and retest to see if we're in that 200 category to start maintaining. So once we get to that point, we want to stay at that point. And so we want to make sure that we're shocking, treating continuously, either with tablets or straws, and then testing quarterly. And again, if we ever have a failure, we want to shock it and retest immediately to make sure that we're in the right numbers. So waterline testing, there are so many different products out and available, and if whatever you're using is working for you, great, keep doing it. I want to bring your attention to a product that I love, and mainly it's because they have such great educational stuff that go along with it. I have been working with ProEdge to help offices get their dental unit water lines maintained for almost a year now. And they just came out with a new product that I'll be talking about here in just a minute. But third-party testing, in a nutshell, it's a test kit that you send in. They test it at their lab, and then they give you the results. If you're interested in the third-party testing, this is typically a 7-day turnaround. And they'll email you as soon as incubation has started, and then email you again with your results after that. If you're interested in this, here is an instruction for use video here, and then your waterline test order here. You can go to that website and get those water tests. Again, their resources are amazing. Here's an example of one of the resources that they have. It gives you a step-by-step instructions for using this kit. Another example of their third-party testing is this new product that they came out with this year called Flow, and it is a same-day water test. Down at the bottom, you can see that there are videos for the instructions for use, a sample test report, and then a place to order. The ProEdge Water Labs is the first to bring you the same-day lab test results with Flow. It's also the most advanced water analysis available in dental. It uses a technology called flow cytometry, which is used in several medical applications, including cancer research, cell analysis, and antibiotic testing. Flow uses laser technology and fluorescence to accurately analyze and count every single bacteria within minutes. Again, using the IFUs and MFUs is so important, and in my opinion, ProEdge has the hands down best and easiest to use educational videos. Again, it's the same day water test results, and again, their resources for step-by-step testing are amazing. If you don't want to do third-party testing and you want to do in-office testing, their Quick Pass is a heterotropic plate count test. Means you can use it in office and use it to determine compliance with the CDC standards for safe water. The dehydrated pad, which you're looking at here, contains both the advanced media formulation and germicidal neutralization. Makes your test more reliable. This takes 48 hours at the least and is easy to use. And again, it's done in office. And again, the resources that ProEdge provides for their users are above reproach. Lab research shows that quarterly testers get the most consistently passing results. At the end of this section, I will give you a link to go and get a sample. But again, you can see here their resources, their quick pass instructions. It shows you after you get done doing your test that you can just take a look at this quick example to show you whether you're passing or not. And if you're not, then you would shock and then you would test again. And so 48 to 72 hour results and done right in the office. You don't have to send it out. You can do pool or combined samples as well. And some opt to do this because of cost. It allows 3 or 4 samples from the same operatory. So not different operatories, but the source from the same operatory. So for instance, if you had an operatory that had your air water syringe, your scaler, your handpiece, those all could go into a combined vial and you can do it with a quick pass as well. It's not just the mail-in, but you do all of those in one vial. And the upside to this is that it saves money to do it this way. I guess if you could call it a downside, you would just see that if it doesn't pass, then you would have to treat the source water, which if you're using the contained water bottle system, you would do that anyway, and you would just shock and maintain those as well. So you can't identify which water line it was that failed. It would just be a collaborated effort to treat the source water and those water lines and make sure that it all passes. Again, the benefit would be a reduced number of testing vials. And if you did a pooled water, combined sample, it's about a 66 to 75% cost reduction. And again, if it passes, all lines pass. If it fails, you're just going to shock the lines and retest them. It gives you a log, which this is one of the things that we're moving toward, is making sure that we have on file documentation of your waterline testing log. And so they give you this on their resource page, they give you this waterline testing log, and you would do, if you're doing a pooled water sample, then you would check more than one of these boxes. You get your data results and your pass or fail, and then you would want to make sure that you state in your program, what do you do if there's a failure? How do we move forward with this? Typically, it's going to be shocking and then retesting, but you have to have that in writing so that everyone knows. Again, waterline shocking. This is just your basic using diluted bleach to shock your water lines. This is often mistaken as unnecessary, but shocking your dental unit water lines is required for every water treatment protocol to be effective. Shocking utilizes a stronger chemical to completely rid your lines of contaminants, and it enables daily low-level antimicrobial products to work most effectively. So when should you shock? Well, you should shock before beginning a treatment protocol and when changing treatment products, at least every quarter once it's maintained, and when your waterline test reveals a contamination level of above 200 CFUs per milliliter. After completing the shock treatment, continue your daily treatment. Now, I'm giving you an example of using diluted bleach here, but be sure that whatever product you're using, you're following the IFUs correctly. Some products include, a lot of the straws include the shock component built into them, and they will be rendered ineffective if you use other products, even bleach, with them. So make sure that you're following your instructions for use, no matter what you're using. And then maintaining. Making sure that you, after you get it shocked, that you use the proper product to maintain your water lines as well. And again, this is one of the reasons why I like ProEdge so well is their resources. You can find so many different resources, PDFs that you can print out and tape on the inside of a cabinet in your office to make sure that you're maintaining compliance. So again, no matter what product you use, be sure your team is trained and that there's some form of accountability or schedule for testing, shocking, and maintenance. The instructional videos at staff meetings are a great way to ensure OSHA protocol is being followed and patient safety is ensured. At the bottom of this, you'll see that you can order the blue tube, which is ProEdge's straw that they use, maintenance straw. And then instructions for use video is also there. And you can see their statistics for waterline microbial counts for the blue tabs and the blue tubes. Once again, just making sure that you follow all of the protocol. There are a lot of good options on the market for waterline safety, and whichever product you choose, just make sure that you have the training and support. Some are more user-friendly than others, and some are more cost-effective than others. So you just have to find the one that works best for you. As a show special, ProEdge has put together free samples and resources, and you can go here and get PDFs, instructions on how to use the Quick Pass, and then down below you can see that they have a Quick Pass water test sample that you can go to their website and order. Again, just even downloading bacterial growth and what that looks like on the heterotrophic plate. And then for their blue tabs, they actually have a show special where you can get a free month's supply of blue tab. And some of you may have started out with blue tabs and used these and then moved to straws, which is fine too. If it's working for you, that's great. Blue tabs are easy to use. I liked blue tab when I was in industry because I could actually dry out the water bottle and not have to worry about what would happen if the straw was dried out. Some products, if the straw dries out, it's rendered ineffective, but with blue tab, you can empty out the water bottle and allow the water bottle to completely dry, and then just replenish it and put a blue tab in afterwards. But again, once again, whatever you're using, if it's working, great. But again, if you wanted a free month supply of blue tab, you could go here and do that, and then they have the research video and the quick start guide on how to get your water lines maintained to begin with. Here you're going to find in the resources, even if you're not using ProEdge products, if you're curious and you want to have some training in your dental office regarding waterline safety, ProEdge has amazing resources, PDFs and stuff, so you can go here and pull their PDFs, their resources to have in your office. And then this link here is it's a YouTube link. Or it's in the YouTube library, and this will take you to all of their videos that highlight their products and give their educational part of their programs. And again, I highly recommend that if you're using a product that you have training and that you find something that maybe has some little instructional videos so that it's efficient and standardized for your whole office. And then, have that in your written protocol too. So the U.S. the U.S. Food and Administration, the FDA, they are now stating that dental operative units and manufacturer responsibilities, the units are Class 1 FDA regulated medical devices, and there is a reprocessing guideline for those, just like reprocessing any other dental device. And so the manufacturers are responsible for making sure that instructions for use are there, that they comply with FDA, EPA, and state and local regulations for disinfection and maintenance of the dental unit water lines. They're required to notify new and past customers of updated instructions and recommendations, and then submitting reprocessing validation test reports for future dental operative units. And so they have some guidelines that they have to follow now to make sure that the dental unit water lines have instructions for reuse. So creating a climate of open communication with a focus on problem solving and learning. We're looking at a positive error management climate, which promotes sharing near misses with supervisors and coworkers, and it's viewed as a learning experience rather than the cause for punitive action. So we want to encourage excellence by creating a culture of safety. I want to move kind of direction now and go into some frequently asked or frequently stated things in training that I have done. I get a lot of, I didn't know that areas. And here's one area where I get a lot of, I didn't know that. So nitrous oxide safety. So For nitrous oxide, the Administrative Rule 042 states that anyone who is providing care with nitrous oxide oxygen must be trained. And the elements of training has to include appropriate equipment maintenance and monitoring, effective scavenger system and mask, devices that prohibit the delivery of less than 30% oxygen, approximately calibrated and functioning inline oxygen analyzer with an audible alarm, positive pressure oxygen delivery system, incident reporting, and scavenging unit. And so incident reporting would include, down here at the bottom, the dentist reporting in to the State Board of Dentistry in writing within 7 days after the death of or emergency transport of emergency center for a treatment proceeding or exceeding a 24-hour of patient to whom sedation was administered. So the short answer to that is making sure that we have incident reporting procedures in place. We want to make sure that we're monitoring the equipment at least annually, but quarterly monitoring is advised. Monitoring each operatory where it's used, labeling the monitoring device for the specific operatory, following the directions on monitoring the device, and making sure that we have SDSs and appropriate labeling available for the use of nitrous oxide. If you're a licensed healthcare provider, so a dentist or a hygienist, then making sure that you have training on this. If you have someone who is in your office that is not licensed but is providing nitrous oxide for patients, they would need to have appropriate training. The American Dental Association updated their pregnancy restrictions on April 1st of 2019 to read that nitrous oxide is classified as a pregnancy risk group category C medication, meaning that there is risk of fetal harm, and it's recommended that pregnant women, both patient and staff, avoid exposure to nitrous oxide. So if you have someone in the dental office, and again, if they have not been trained, they would need to be aware that there is a risk with being pregnant and using nitrous oxide. For more information on that, the source here is ada.org, and then you can follow that link to find out more information about that. Moving from nitrous oxide to radiation, and the standard that applies to that, and having X-ray machines. Obviously, the person that is responsible for the X-ray machines has a certain protocol to follow to make sure that those X-ray machines are maintained properly, including making sure that the person that is providing service on those is certified to do so. And then a survey of the types of radiation used in the facility, including X-rays, restricting areas to limit employee exposures. Employees working in restricted areas must wear personal radiation monitors, such as film badges or pocket dosimeters, and then making sure that it's documented and kept, the reports kept. And then making sure that the rooms and equipment are labeled and equipped with the appropriate signage. So qualifications for authorized operation of X-ray machines. When do we monitor? When do we remove ourselves from the room? Never hold sensors or films for patients. There are some different guidelines on this with the Nomad, the handhelds. So making sure that whomever is utilizing those things is trained and knows the appropriate exposure for that. Know how to operate your X-ray machine, and then keep state radiation inspection reports. Also making sure that the certification stating that your X-ray machine is in appropriate working order. Make sure that they are posted on the wall near each unit, and then making sure that they are licensed appropriately. Again, that's an administrative rule. And then making sure that, again, the qualified authorized service and repair of X-ray machines is done appropriately by the appropriate person, and then the documentation is retained for 2 years. The goal for the State Board of Dentistry is to inspect facilities on their appropriate practices during their current licensure period, which would be every 4 years, and that just depends on how current they are with those audits. So many of you have had an audit from the State Board of Dentistry recently. I've gotten phone calls from you, and many of you have had audits, so you know that they do come through and they inspect, and so be prepared for that. There are some do's and don'ts. I'm not going to go down this whole list. You have the capability of looking down this list, but you do need to make sure that you are protecting yourself against exposures and from a dosimeter. There are some things with the dosimeter though. If you have had a dosimeter and you've had them read every 3 months for a year and there have been no issues with the reporting and stuff, at the end of the year, after wearing them for a year, the reports can be sent to the Idaho Bureau of Laboratories and a waiver can be requested. And here is the link to that. And this can be filled out, and the waiver can be requested for those that have had an accurate report every 3 months for a year. If you have a new hire, obviously they're going to need to wear that for a bit until they can fill out a waiver as well. As far as training and documentation, if there's someone that is in your office that needs training on X-ray and how to provide that service for patients, or if you know someone that wants a refresher course, that Idaho Department of Health and Welfare, Idaho Bureau of Laboratories, they have an X-ray basics course, and then they have a training log that will be needed for documentation. So if you have someone in your office that is providing X-rays for patients, they need to be trained. Here's the link down at the bottom to do that. And then you'll need the documentation stating such. So those are two of the most asked questions that I get: the nitrous oxide and the radiation, the X-ray training. Two of the questions that I get most often. So I wanted to cover those just a little bit. And so to end, what I wanted to do is just let you know that the services that I have available are your annual OSHA updates, which are in office. It's about a 3.5-hour training. And it's that annual OSHA update. It's a flat fee, so it doesn't matter how many people are in attendance at your office for your particular office. And then I do that face-to-face. We would use universal source control, of course. And so I do those. Consultation or walkthrough to identify potential compliance issues. Oftentimes, if you're a new office or you've started a new program, folks would hire me to come in and do a walk around and have a fresh set of eyes look at things and make sure that everything is in place and compliant. I do also have a written OSHA and patient safety program that's available for purchase, one-on-one mentoring. So perhaps you've had a program in place for a while, but you have someone that is new on staff, or maybe just needs some one-on-one mentoring with the existing program that you do have to make sure that they are doing it correctly. It helps build confidence with them. I do also provide hands-on in-office courses, and you can go to my website, which I'll show you on the next slide, to see a list of those courses. And then I also provide respirator fit testing for those of you using respirators in office. And so to contact me for any of that, you can go to my social media and like and share. And then you can also go to truenorthtrainingandcompliance.com. My email's there. And I would love to hear from you if you have questions. So thank you again for letting me join you today. I hope you found this valuable, and I look forward to working with you again. Thanks.